Assalamu alaikum everyone and welcome to the today's webinar. I am Dr. Raham Bacha, Head of the Department, University Institute of Radiological Sciences and Medical Imaging, the University of Lahore. Alhamdulillah, we have successfully started a series of webinars on medical imaging with the collaboration of Afro-Asian Institute and University of Lahore. The topic of today's talk is why cervical sonography in pregnancy, and the speaker is worldwide renowned educationist, Professor Dr. Said Amir Gilani. Question answer session will be given proper time at the end of this webinar. All your questions will be addressed, inshallah. Secondly, ultrasound is a vast field with a variety of subdomains and specialties. Hopefully, you will find it very interesting and knowledgeable. A recorded version of this webinar will be available on YouTube. We would like to hear from you. First of all, I would like to introduce our today's speaker. Professor Dr. Said Amir Gilani is our today's presenter. He is the founder dean of the Faculty of Applied Health Sciences at the University of Lahore, Pakistan. Founder dean of Allied Health Sciences at the University of Lahore. He is the country director of Applied HE. He is educational psychologist and academic advisor to a dozen of international universities. He is the author of more than 365 internationally published articles and 11 books. He participated in thousands of international seminars as speaker and almost traveled the entire world. He has more than 2 decades of experience in medical diagnostic ultrasound. While taking advantage from his experience and expertise, he will introduce us with the usefulness of cervical sonography and pregnancy. Now, without any delay and taking much more time, I would like to request our respected presenter, Professor Dr. Said Amir Gilani, to enlighten us with the precious knowledge by taking the mic.
Bismillah ar-Rahman ar-Rahim, with the name of Allah, the most merciful, the most beneficent. I'm thankful to our moderator, Professor Dr. Raham Bacha, and our team of Afro-Asian Institute of Medical Sciences for organizing all these free webinars to share knowledge and experience with our students, colleagues worldwide. Today our topic is why cervical sonography is essential in pregnancy, and I am Professor Dr. Sayyid Amr Gilani. Cervical sonography, I personally believe that it is a part of first and second trimester sonography, which is usually ignored. It is not given that much time, and usually the pathologies of cervix are ignored. As we know that there are different parts of uterus, like the corpus of the uterus, and we have got cervix. Usually in pregnancy, as the fetus is there or gestational sac is there in the endometrium in the body of the uterus, so we usually, as sonographers or sonologists or radiologists, we look at the fetus, we look at placenta or gestational sac, amniotic fluid, cardiac activity, and we don't look at the main door, which need to be closed to protect the fetus to stay inside the uterus till it is delivered with pains, or if there is no labor pain, then it can be delivered by a cesarean section. So before the pain start or the time of delivery, we need the door to be closed. The door is internal and external os of the cervix. So the first thing is it is mostly ignored, and I usually think that we must spend about 2 to 3 minutes assessing the cervix before going to the body of the uterus or gestational sac or whatever is there. We can have different pathologies in the cervix, but today the main topic is about the role of cervical scanning, and most important thing is preterm labor. So if the cervix is not good, is not patent, is not properly protected, or is short, it can be congenitally short, or it can be due to many other reasons which we will discuss. So the lady can have preterm labor, and we can face an abortion in the end of first trimester or in early second trimester. The causes of preterm labor are 75% of perinatal mortality and 40 to 50% of neurological handicap. We use different diagnostic tools for prediction of preterm birth, and digital examination of cervix is one of that. Then we can use sonographic evaluation of cervix. We can have fetal fibronectic assay in cervicovaginal secretions. We take a swab from the cervix, which are the cervical or cervicovaginal secretions, and we look for fetal fibronectic assay to assess if there is any chance of any abnormality. So out of these, digital examination of cervix, sonographic evaluation of cervix, and fetal fibronectic assay, we have seen that the most important thing is sonography, which can help us. For the prognosis of preterm labor, there are four things which we have to keep in mind. The first is cervical length, fetal fibronectin, which we just discussed that we look in the cervicovaginal secretions, Bishop score, which is scoring for the cervical incompetence, and premature contractions. If we find any premature contractions, that can also indicate that the lady can have a preterm labor. How these preterm contractions are diagnosed, the patient will come to you with lower abdominal pain and off and on pains. So we can diagnose it clinically. The sonographic diagnosis of cervical incompetence, we prefer to have TVS examination of cervix, the best imaging modality for detection or exclusion of patients at risk for preterm birth. So TVS is very important. We consider the assessment of cervical length, shape of the internal cervical os. So in practice, most of us are measuring the length of the cervix, but we rarely bother about shape of the internal cervical os. We have to look at its appearance also. For prediction of preterm birth, which may minimize perinatal morbidity and mortality, the shorter the cervix, the greater the risk of preterm delivery. So we have to look for its size. We usually take about 1.5 to 3.5, and in some studies we take about 4 centimeters as normal. We will discuss later in this lecture. The cervical length measurement method. First thing is how we measure it. For transvaginal measurements, you can see the probe is inserted, and this will be the cervix, and we measure it from here to here. Here is vagina, and then is the external os, internal os, and cervical canal. And this is how it appears. Here is the external os, internal os, and the cervical canal. There are many studies about TVS measurement of cervix. For instance, there are 2 studies by Corlin and Krepp. It says that it is a safe method. Then there is another study by Duta et al. He says that it is well tolerated if we perform TVS. Very accurate by 2 studies from Berger et al. And Berry Gold et al. But the accuracy is inter-observer variability. So we can have variability among the observers. So it is accurate, but it depends who is performing. Then is another study. There are 2 studies, and according to that, study is better than digital examination. It is more objective. There are guidelines which are called BJOG 2009 guidelines for proper technique of TVS for cervical screening. It has got 11 points. The first step is empty bladder. Once a patient comes, we do the transabdominal scan with full bladder. Then we advise the patient to empty her bladder. Then prepare the clean prop covered by condom. We clean the prop and we put some gel, and then we cover it with the condom, and then we put gel again. The third point is insert the prop. Prop can be inserted by the woman for her comfort if she is not feeling comfortable. If the doctor is inserting, then it is better that we allow her to insert herself. The fourth point is guide the probe in interior fornix of vagina. Then obtain a long axis sagittal view of the entire endocervical canal. So first we will clean the probe, cover it, insert it, then we will move it towards the anterior fornix of vagina and try to get the long axis sagittal view of the entire endocervical canal. Then withdraw the image until the image is blurred. If you find the image is blurred, then slowly withdraw it, bring it outwards and reapply just enough pressure to restore the image. So we will just move it back and then we will insert some pressure to avoid excessive pressure on cervical canal which can elongate it. So we must apply a gentle pressure, because if we put more pressure, it will elongate it. So the length will not be properly measured. The seventh point in the guideline is enlarge the image so that the image occupies 2/3 of screen and both external and internal os are visible. Then measure the cervical length from internal to external os along the endocervical canal. Obtain 3 measurements and record the shortest best measurement in millimeters. So we will have 3 measurements and then we will take the shortest one, because we are afraid that because of probe pressure, we may elongate the cervical canal. Therefore, we prefer to take the shortest one and we take 3 measurements. Apply transfundal pressure for 15 seconds and record cervical length again at least 3 times, recording best measurements. So we will put the pressure for 15 minutes, record the cervical length for 3 times, and record the best measurement, which is the shortest measurement in millimeters. The last point is entire examination should last at least 5 minutes. Record only the shortest best measurement cervical length for best management. So if we look at it, we will ask the patient to empty bladder, prepare the probe, insert it, guide in the interior fornix of vagina, obtain a long axis sagittal view of the entire endocervical canal, withdraw it if it is blurred, and to avoid excessive pressure on cervical canal, we will give a gentle pressure. Enlarge the image, which can occupy 2 to 3 part of the screen, two-thirds of the screen, and then measure the cervical length from internal to external os, and we will include the endocervical canal, obtain the measurements and record shortest, apply transfundal pressure for 15 seconds, and record cervical length again at least 3 times. So the process will take about 5 minutes, having 3 measurements and considering the shortest measurement. For sonography of cervix, we use 3 approaches. First is transabdominal scan, then is transperineal or translabial. We put the transducer at the labia, and transvaginal approach. Here is a scan. You can see this is urinary bladder, and we are performing transabdominal scan, and we can see the cervix. So cervix is not very clear in transabdominal scanning. This is how we will measure it on transabdominal scan. Then comes transperineal or translabial. The probe is at the labia, and here we can see the cervical canal, and here will be the fetal parts or amniotic fluid. This is transvaginal, where we can measure it from here to here, and then is the uterus. The sonographic features of cervix include cervical length and funneling. We will see how much is the cervix And what about funneling of the cervix? For measurement of cervical length, this is internal loss and external loss. Here will be the vagina, and after vagina there is external loss. This is cervical canal and internal loss. So this whole area is to be measured for cervical length. So it will be like this from here to here. If possible, we will measure a straight line. This is how we measure from internal to external loss. And here it is. If it is curved endocervical canal, this is a way to measure, but it will not be accurate because it is curved. So we will not measure it like this way. We will prefer to have two spots, 2 points measurement. First point from where we start and second point from where we start. So this will be one measurement and second measurement. Then we add up these two measurements. We can also trace it to have the length of the cervix if it is curved. This is how we trace it. Another cervix which we are tracing from internal to external loss. If it is short cervix, this is how we will measure. Identify internal and external, the internal loss and external loss, and then we measure. So if you find that the straight line is not very much helpful, we can have two measurements, one coming from here to here and then the second measurement if it looks that it is a bit curved. The second thing in cervix along with the length of the cervix is funneling. And this is funneling in which we will see that the internal loss is closed or open. If the external loss is closed, the cervical canal is almost closed, but there is a part of cervical canal along with internal loss opening. We call it funneling. It is funnel-like shape. Cervical length and funneling, there are different studies according to Tabor et al., which was published in 2010. We can say that if the cervical length is less than 6 millimeters, related to funneling, we will have chances of 100% funneling. Then is 6 to 10 mm, 9.98%. 11 to 15 will be about 98. 11 to 20 millimeters, which means 1.6 to 2 centimeters, there will be a chance of 51. So I told you that usually the measurement, if it is usually about 1.5 to 3, the most accurate is above 3. So we ideally look for 3.5 to 4 centimeter length of cervix. So if it is like this, there will be 98 to 100% chances if the cervical length is 1.5 centimeters or less, which is 15 millimeter or less, there will be 98% chances that there will be funneling of the cervix, which we call cervical incompetence. But if it is 2 or below 2, 51% chances. If it is 3 or more than 3, then just 0.5% chances of funneling. Cervical length measurement, as we saw before, and this is the funneling. Here is the external loss, the cervical canal. External loss is open. It can, a normal cervix can be of T shape, but we can have W shape, V shape, and U shape. Like here you can see, this is the dynamic evaluation of preterm cervical shortening and dilatation in prediction of preterm delivery. A scan which was performed at 24 weeks. And you can see this is the T shape. if it is normal. If there is a groove dipping down at the level of internal os, we will say it is Y shape, because this line will come here and it will be Y shape. And then is V shaped, in which along with the internal os, a part of cervix is also dilated. So cervical canal, about 25% or less than 25%. If the cervical canal is dilated along with dilatation or opening of the internal os, we call it V shape. And if we ask the patient to stand while lying supine, this patient was diagnosed as having V shaped. But when she stood up, this is how the weight of the fetus is causing pressure on the cervix, and whole of the cervix is open. So it will be like U shape. And if the fetus is at at the end of first trimester or second trimester, early second trimester, we usually label it as open cervix, U-shaped cervix with impending abortion. As I discussed, the funneling is dilatation of internal os. The internal os will be open. This is another case in which you can see the longer the funnel length, the shorter the cervical length. Because then we will measure this one. Although the internal os was here, but as it is open, so we will start measuring from the area of the cervix which is not open. This is funnel width. Then is the funnel length from here to here, and cervical length. So we will say that if it is 3 centimeters long and 1 centimeter is the funnel length, then we will say that 33% of the cervical canal is dilated. If this area is 1.5 centimeter and intact area is 1.5 centimeter out of 3 centimeters total, then we will say 50% of the cervical canal is funneled or is incompetent or is open. So this is how we measure the two ends. We measure the length and we measure the intact cervical canal. There is again the T shape, Y shape, V shape, and U shape. In T shape, it is normal. Both internal and external os are closed. Then we measure the length, which must be 1.5 to 3.5, and ideally is above 3, which will be ideal. Then is Y shape, in which the internal os is open. Then is V shape, in which the cervical canal along with the internal os is open. Only the thing which is intact is the external os which is closed. And then we come to U shape, in which everything is open and there is impending abortion, the abortion in progress. In cervical canal in second trimester, the cervical measurement during the second trimester of pregnancy is a useful method for the prediction of preterm delivery. The shortest the cervix during the mid-second trimester, the higher risk of preterm delivery. These are many references from 1995 to 2009. You can find all these things. This lecture will be recorded and it will be uploaded on YouTube, so you can get all the references. The gestational age and measurement of cervix, 18 to 22 weeks, there is correlation, and we have some of the publications from 1999-2002. Then is 20 to 24 weeks, there is correlation between cervical length and preterm delivery, and we have Calais et al. Then 22nd to 24 weeks, we have a fetalmedicine.com website from where we got the reference. What are the cutoff limits? So we usually say that 15 mm is second percentile, 25 mm will be 10th percentile. These are the references. So it must be at least above 25 to avoid the 10th percentile. Here it is again, the risk of preterm delivery in second trimester. This is the percentage. And here are the millimeters, the length of the cervix. So if it is above 3.5, we don't have any risk. So the ratio of risk, which is risk ratio decrease is almost, there is nil. But from 3.5 to 3.1 to 3.5 will be a very small risk, which is about 0.5%, and then it increases in percentage with the length. So if the length is less than half centimeter, you can see that it is almost 70%. And previously we saw some references that it will be about 98%. Cutoff limits according to type of pregnancy. The low risk pregnancy, the cutoff limit is 15 mm. High risk is 25 mm. Twin pregnancies is 25 mm. And multiple pregnancy is 25 mm. This is the cutoff limit for the lowest, shortest cervix. Women with cervix, which is less than 25 millimeter, 10th percentile, at 24 weeks gestation have 6 times greater risk of preterm pregnancy, preterm delivery, and those having less than 3.5 centimeters, less than 35 weeks, compared to women with cervix, which is at 40 mm or above 40 mm, there will be 75th percentile. So there is another interesting thing. Here you can see that gestational age at 3 weeks, if the cervix is above 60 mm, the risk ratio will be, which is just 0.1% risk. If 21 to 30 millimeter, then 1.1%. 11 to 20 is 4%. But if it is less than 10 millimeters, which is 1 centimeter, the risk is 78%. And as we saw in another slide, that if it is 5 millimeter, it goes to 98% risk. This was about 23rd week. Then after second trimester, we come to cervical length at first trimester. In first trimester, we again measure the cervix. This is how we measure it. There it is. We can see the cervical canal by a TVS. And if you look at it, this was a study which was done on 1,508 women at 11 to 13 weeks by endocervical measurements. The delivery, which is after 34 weeks, the length was 32 millimeter, and then PTL was about, which was less than 34 weeks, then it was 27 mm, according to this study on 1,508 women. The cervicoisthmus size was 45 and 41, whereas the other age group is 20 to 24 weeks. Out of this study, it was endocervical length was 32 mm and 21 mm, and cervicoisthmus was 41 mm and 27 mm. So these were two groups at 11 to 13 weeks, which is the first trimester, and in the second trimester, which is 20 to 24 weeks. These two studies were done, and if the fetus is delivered after 32 weeks, then these were the measurements. And if the fetus was delivered before 34 weeks, then the size were this much. You can see the difference. Delivered means preterm delivery or preterm labor. So before 14 weeks of pregnancy, cutoff limits of cervical length or 27 mm and 30 mm that were used had no prognostic value for the prediction of preterm delivery. Women who delivered before 37 weeks were found to have shorter cervical length than women who delivered at term. So if somebody is delivered before term, before 37 weeks, we have to consider that she might have shorter cervical length, although it was within the normal limits, but it was shorter. Cervical length at first trimester has a prognostic value for the preterm delivery and less than 37 weeks, and that the optimal cervical length with the best accuracy was 38.4 mm, which is 3.8, but with a very low specificity and sensitivity. So in these studies, this was our conclusion that if we get almost 3.8 mm, it is safer. And the pregnancy can reach, if we get this length in first trimester, the pregnancy can reach up to 37 weeks. Identification of high-risk patients for the preterm delivery may be possible before 14 weeks. More studies to define exact relationship. Shifting the screening process towards the first trimester, more studies are needed and intervention and treatment options are there. Thank you very much for listening. The mic is handed over to Professor Dr. Rahim Bacha.
Thank you very much, sir. We are very thankful to our respected presenter, Professor Dr. Said Amir Gilani, who delivers a very productive and useful lecture, knowledgeable lecture. Now we have some question, and we'll try to answer only relevant questions. So the first question is from Saliha Tariq. She asked about if a patient didn't have any ultrasound earlier at 25 week, she have doubt of cervical infection and asked to have TVS to see the extent of infection. Is it safe? Is it not open the internal os?
The patient had not done ultrasound.
Respected sir.
And it is 25 weeks. She has doubt of cervical infection. So if there is doubt of cervical infection, I think it will be better to have PV examination by the physician or by obstetrician. And if the doctor has recommended to have TVS to see extent of infection, yes, you can see cervicitis or by TVS or by translabial. I will prefer to have transperineal or translabial ultrasound instead of TVS, so that the cervical infection must not be extending to the internal os or towards the body of the uterus. So it is better to have translabial, but if you are doing TVS, you can do it. You will find the thickening of the cervical canal, and there will be signs of infection with high premium color Doppler. I think it will be safe. It will not be causing any opening of the internal os. Unless there is labor pain, the internal os will not open by inserting the TVS prop. Yes, the next question is.
Okay, sir. Thank you very much for your question.
Yes.
Answer. Patient having PCOS, then is it safe to? Yeah.
If patient is having PCOS, then it is, yes, it is safe to have TVS. There will be no problem with the TVS. The TVS probe is transvaginal sonography. The transducer remains in vagina, and vagina ends up at the external os. So the probe is not, the transducer is not inserted in cervix. So it will not open the external os, it will not open the internal os, it will not touch the fetus. it is going to maximally, it will touch the external os, and by touching of probe, the external os is not going to open. So the RPOC is will be there. If patient is having PCOS, yes, we can perform TVS. There is no problem.
Okay, sir. Respected sir, what's the effect of urinary bladder fullness on cervical length measurement and transabdominally?
If it is overextended, if it is not appropriately full, then it can create pressure on the cervix, because cervical canal has got cervical lips. There are no muscles in its wall, so it is just serosa and mucosa. So once there is pressure, it will elongate it. So we can get a false measurement of large normal cervix. If cervix is, for instance, 3.5 centimeters and there is extended bladder, it can go up to 3.8 to 4 centimeters. So that much pressure is expected. So better to have appropriately full bladder, not overextended. It will elongate it.